So, good afternoon, and very quickly to answer this question, antimicrobial therapy, monotherapy versus combination therapy, do we have answer? So, my answer is I don't know, because it's not me only, even Surviving Sepsis campaign, if you have read, they also don't know. The recommendation which they have, I'll just let you know what they recommend about and why they recommend about. But still we don't have a very hard-code randomized controlled trial which clearly says that monotherapy is superior to combination therapy or combination therapy is superior to monotherapy. Okay. So, just a few terminology. What do you understand by empiric therapy? When we start antibiotics in a given situation where we don't know what we are treating, and we probably want to cover every possible bug. So, initial therapy they recommend should be broad enough to cover all suspected organisms. How we suspect organism? I will come to the criteria. That means your empiric therapy is going to be mono, combination, broad spectrum or multi-drug in nature. Where do you place? I will let you know. When we come to target or definitive therapy, here we know the organism and we start treatment. So, when we know the organism is starting treatment, why do they need to recommend the targeted therapy may be mono or combination, but is not intended to be broad spectrum? Here again they have confused you. These are all definition I am taking from guideline. What is saying? What we understand by broad spectrum therapy, according to their definition, one or more antimicrobial agent with the specific intent of broadening the range of potential pathogen covered. Means, if I want to treat Pseudomonas, I want to give 3 drug to eradicate it fast. But it's not like that. You can have Pseudomonas, you can have a patient also fungal infection or MRSA also. So here they want to give piperacillin tazobactam to cover Pseudomonas, they want to give vancomycin for MRSA, and they want to give inhaler fungin for suspected fungal infection. This is broad spectrum therapy. The rationale behind this is they want to ensure that at least one antimicrobial should cover the probable bug, and then multi-drug therapy. Multi-drug therapy can be empiric where we don't know, or it can be definitive where we want to accelerate the clearance, like we combine piperacillin tazobactam with aminoglycoside. And then comes the combination therapy. What I mean, when anybody talk about combination therapy, what it means? If we go by this definition, piperacillin tazobactam, vancomycin and enrofungin do not fall in the combination of classical combination therapy as per this definition. It comes under the broad spectrum therapy where we want to cover the probable bugs which we suspected. But when we say it's a combination therapy, it means we want to use multiple antibiotics, usually of different mechanistic classes, with the specific intent of covering the known or suspected pathogen with more than one antibiotics. The classical example, piperacillin tazobactam, aminoglycoside, piperacillin tazobactam, quinolones or azithromycin. Purpose is to accelerate the clearance. Or you want to inhibit the bacterial toxin by adding clindamycin or azithromycin. Or you want to potentially use as an immunomodulator, like nowadays we use azithro or clarithromycin. The term is not used to broaden the range of antimicrobial activity. So here you have to very clearly understand that when we say combination therapy, it means we are intending to kill one bug where we probably know or know with 2 or more drugs to accelerate the clearance, according to this understanding. Okay. What do I mean by combination therapy? When I combine 2 drugs, it can be synergistic. That means combining 2 antibiotics, the effect will be more than their individual effect. That means 1 plus 1 is 3 or 11, not 2. While we say additive, it means 1 plus 1 is 2. That means if you combine both the drugs, the effect of individual will be equal to the combination. But if it is antagonistic, it means due to some reason, if you have combined 2 antibiotics, they can cut down each other effect and effect may be less than 2. This is also very much possible. We need to be very careful when select antibiotic that we are not using antagonistic. Plus, most commonly used antibiotic nowadays is when you are combining colistin with tetracycline to treat pneumonia, particularly hospital acquired Acinetobacter pneumonia. There it has been found to be antagonistic effect. Now, as per their recommendation, what new guideline recommend? We recommend empirical broad spectrum therapy with one or more antimicrobial for patient presenting with sepsis or septic shock to cover all likely pathogen. Okay, this is what they say. The intention is they want to cover all the probable bacterial or fungal or viral infection. And the rationale behind this is, if you delay in starting appropriate antibiotic in time, each hour delay increases the chance of increase the mortality in the patient. This came from one of the very important study from Dr. Kumar. And another problem is that if you delay in starting appropriate treatment, probability of progression from gram-negative bacteremia to sepsis or septic shock increases and mortality increases. So this is one of the biggest fear when we select antibiotic. We probably want, all of us want to save the patient, and intention behind that is with these studies that we want to cover all possible bugs, and that's why we combine antibiotic. How we select appropriate antibiotic? We go by the site, probably by antibiogram or pathogen we know resistance mechanism, the presence of immune defect, comorbidity, antibiotic exposure, all this, and based on this there is a scoring system where you define which class this patient falls in, and accordingly in sepsis or septic shock we select antibiotic for any given site or pathophysiology. Their suggestion was combination therapy not be routinely used. Again, they are confusing you more. It should not be routinely used for ongoing treatment, means if you have continued the treatment for most serious infections including bacteremia and sepsis without shock. So if your patient is not having septic shock, as per new definition, if your patient is not in septic shock, you don't need to start combination therapy. But it doesn't mean you will not start broad spectrum therapy. You will, according to a scoring system, you try to predict the probable bug, start the broad spectrum therapy, but you will not start the combination therapy. That means no need to start in general piperacillin, tazobacter or amikacin. If you are starting piperacillin for gram negative or meropenem for gram negative, one should be enough. Or if you are suspecting like that. So in general, if your patient is not in shock, but if same patient is in shock, in general, everybody recommends for the combination therapy. That's one thing is very clear. When you are dealing with neutropenic patient, if your patient is neutropenic and patient is having only fever or bacteremia, not septic shock, again no need to combine the antibiotic. In general, in neutropenic patient, that's the only class of patient where combination of antibiotic has shown negative result. So there is a very strong recommendation that you don't need to combine. But again, this does not preclude us from multi-drug therapy to cover antimicrobial. So if you are not clear about what combination, what broad spectrum or multi-drug therapy is, you will always be confusing this term. If you have started combination therapy, once patient start improving, you need to bring down for monotherapy in targeted or empiric therapy. Targeted therapy, I am okay. But if I started somebody empirical treatment and I don't know what bug I am treating, after 3 or 5 days, how can I come down and which antibiotics I should start? I don't know the way. If my patient has started on suppose colistin or meropenem combination, which antibiotic I should stop after 3 days or after 72 hours? If I don't have culture report, I don't know the way. But that's what they recommend. But here I have a serious question about that. Why do we combine antibiotic? The basic reason is we want to start initial appropriate antibiotic to decrease mortality. Everything, whatever is the reason here, but basic intent is that. Indication, if you have polymicrobial infection like abdominal sepsis, infective endocarditis and meningitis, pneumonia, very strong recommendation. I did not take because TB and HIV is not our subject primarily, but there we know the and if there is a severe infection with septic shock and multi-drug resistant organism. But all these recommendation is based on just retrospective studies or personal case based experience. It's not a definite RCT based recommendation. Combination can prevent resistance. We know in tuberculosis and HIV, and we know the reduction of beta lactamase production reduced. But if it happen, probably beta lactamase has never have come. Probably it could not do for ICU patient. But this is the basis of doing that. Now coming to the why do we say that antibiotics should be combined? What is the data we have? Particularly in this paper, because this paper has made recommendation for a lot of studies and lot of guidelines where this paper is being quoted why we need to combine. Early combination of antibiotic therapy yields improved survival compared with monotherapy in septic shock. This was a big paper by Dr. Kumar where he have analyzed even hour by hour. Not only he analyzed the time, he analyzed the combination and how fast you give antibiotic. And there he have very clearly they have said in a subset of patient where your patient is having septic shock, combining two antibiotic of different mechanism helps in improving the outcome. Same thing, and this is how he has shown, but he has very clearly also said if your patient is not having septic shock, our risk of dying due to sepsis is less than 15%, but if he comes in lower category, and in that case if you combine antibiotic, possibility of increased mortality is high. So one issue is very clear, if your patient is not having septic shock as per current definition, you don't need to combine antibiotic. If you get a patient of sepsis with septic shock, you combine. If it's not there, you don't combine. You wait till you get definite culture report to start appropriate antibiotic. So okay. Same thing, he again re-emphasized in this commentary that combination antimicrobial therapy where a given pathogen is covered by two and more antibiotic with different antimicrobial mechanism by use may be useful in a subset of clinically ill patients, particularly those with septic shock. Okay. Here, this was a very big commentary in our Indian Journal of Critical Care Medicine where he tried to see the current concept in combination antibiotic therapy for critically ill patients. The first line was, although it's a widespread use of combination antibiotic, but we don't have a definite data to support that. But more than one antibiotic is commonly used to treat such infection. Scientific evidence are not in favor of that, particularly if those bugs are MDR and XDR. It was a very nice communication and review of what is done, whatever reason it has been given. But again, if your bug is MDR or XDR, if you are suspecting, then combination of antibiotics make a case for this class of patient. But particularly for community acquired pneumonia, lower respiratory tract, in a patient which comes in category of 3 and 4, patient who needs ICU care, patient who comes with pneumonia with septic shock who needs ventilator. This has been a very, very strong recommendation from all guidelines that you need to combine antibiotic till you get different culture report, and this has been undisputed recommendation and followed by. So this is one place where you will combine antibiotic to cover all probable bugs, including atypical and probably toxin producing bugs. Sometimes even you need to combine for gram-negative 2 bugs, for atypical bugs like azithromycin, or sometimes you need to give even if you are suspecting MRSA to cover MRSA also in this class of patient. So here there is a patient which makes where you have to think for all those categories including combination and broad spectrum antibiotic. And very clearly it has been shown that combining antibiotic in community acquired pneumonia, particularly severe community acquired pneumonia, improves outcome. A fact about community acquired pneumonia that 10% of these patients may have bacteremia, and this is because of the pneumolysin and toxin produced by this pneumococcus, and adding macrolides here is an advantage. So this thing we need to remember. Combination therapy, if I start going by data, there are some where they have compared piperacin, tazobactam and amikacin with amikacin. Probably it was not a fair thing to do. There is a definite advantage of combination therapy. But again, Beta-lactam monotherapy versus beta-lactam and aminoglycoside, there was no. So if you just compare beta-lactam and aminoglycoside with beta-lactam, there was no difference. But again, for pneumonia, as I said initially, there was a huge difference in outcome. In neutropenic patient, it's very clear that you don't need to all ideas say, all the guidelines clearly say that you don't need to combine antibiotic. You need to give broad spectrum antibiotic, but you don't need to combine antibiotic as long as this patient is not having septic shock or on ventilator therapy. For fever or bacteremia, you don't need to give combination therapy for neutropenic patient. Generally, the meta-analysis for all the trial which has been done for combining antibiotic favors combination therapy in gram-negative infection. But whatever small trials are there, they do not favor combination therapy. What are the adverse events associated with combination therapy? It can be nephrotoxicity, class superinfection, fungal overgrowth, and sometimes antagonism we need to worry about. Particularly antagonism, you have to worry about 3 cases. As immunocompromised, that's why we don't combine. And when you are dealing with severe infection like localized meningitis and endocarditis. If your combination of drug is not appropriate, there is a high chance the same drug may become antagonistic to each other. So you need to be very careful when you are selecting your antibiotic. For carbapenem resistant Enterobacteriaceae, we have talked in detail that we combine fosfomycin and colistin, and that's why all the review articles favorable. But nobody has a definite trial to say that. So, as far as salvage therapy of multi-drug resistant infection is concerned, there are very limited observational study, but everybody advocates consideration of combination of 2 antibiotics. Of late, there are few studies, particularly prospective studies, which has come where people have started combining single colistin versus colistin combination. And I will not be surprised that in coming time, if somebody start advocating despite heteroresistance is there, that the colistin alone and colistin plus carbapenem, colistin plus other combination, if it is sensitive, is equally effective. So there are data where high dose colistin is being compared with other and found to be. And then in fact there was a big discussion on CCP one time when we were talking about combination therapy, where Dr. Farhad has said that he only used colistin. That's why he was the only person who quoted that I use only colistin to treat the sensitive bug, no other drug I combine. But there are few data which has started coming. If I get enough, I will also get confident to use standalone colistin. So far I do not use it. Very few small case reported, which is very interesting when the fosfomycin was not there, where people have started combining 2 carbapenem as a synergistic effect, particularly for Klebsiella pneumoniae. The ertapenem, particularly it works on Klebsiella, but when it becomes resistant, to increase the efficacy and to get additive effect, meropenem, carbapenem has been combined to treat. I had also treated around 5% when fosfomycin, but definitely it has worked for resistant Klebsiella. So if you don't have option, sometime you can try this combination for resistant Klebsiella. So just to conclude my talk in 2 minutes, the clinical data supporting combination therapy are neither overwhelming nor definitive. Meta-analysis evaluating RCT demonstrate no difference in clinical output when the 2 treatment strategy for definite management of infection with gram-negative infection. Well documented increased toxicity with combination therapy, you need to be careful. Gram-negative bacteria are served best with monotherapy, and it's always appropriate if you know the bug and if patient do not fall in the category of shock or immunocompromised or severe immunocompromised category, you may go with the single bug. Initiating broad spectrum empirical antibiotic therapy at the first suspicion of infection in critically ill patient is important, but you need to come down. When you suspect multi-drug resistant infection, including patient with compromised immune system, with various ICU admission, recipient of broad spectrum antibiotic, empirical antimicrobial treatment should include coverage of pathogen that may be resistant to previous administered antibiotic. This you need to always consider, because suppose somebody was in therapy, was on piperazine tazobactam, has come to you with sepsis. You will not only suspect that patient may be resistant to that bug, but may be having pan drug or extensive drug resistant, and when you will select the gram negative, antibiotic coverage, it must cover the extensive or pan-drug resistant coverage. But to avoid the further emergence of resistance and adverse side effect, antimicrobial regimen should be narrowed down. So we all recommend that we need to combine when there is adverse or septic shock. If there is no septic shock, a patient do not fall in the category of XDR, MDR category, selection of any single drug. But when I say single drug, I am talking about gram-negative coverage. If you suspect somebody is having MRSA and gram-negative, that's not a combination therapy. So two messages I want to give. You need to be very, very clear what you are doing. Are you doing broad spectrum coverage or you are doing combination therapy? And when you are combining, you need to be very, very clear that it should be, your patient should be in shock, septic shock, or should be having immunocompromised status, are very high likely to die because of that. If it's not there, if you can wait for 48 hours till culture report comes, single antimicrobial will be as good as combination. But all these are based on the personal experience of everybody else or small case reported. We do not have a very big RCT to compare one versus other. And that's the reason I don't know clear answer. But this is what I know about combination versus single. Thank you.